Hey everyone, my name is Lior Bibas. I want to thank the organization committee for taking me out of our cold winter to not really warm weather, but it'll do. So I'm going to present to you a case of a VT storm we had in Toronto, and then I think it'll be a gateway to the next two talks after this. So I have no disclosures. So I'll talk to you about Mr. B. So Mr. B is a 28-year-old male, originally from Venezuela. He works as a car salesman, has a family with one child. He was diagnosed in 2008 with ventricular tachycardia when he presented with syncope, but upon history found out that he had arrhythmia and palpitations since childhood in Venezuela. At the moment, he was on flecainide and had multiple failed attempts of antiarrhythmic therapy in the past. He had two ablations in the past that were failed for diagnosis of what was called fascicular VT. And we found a CMR in 2014 with an EF of 53% with no LGE. And he also had a pretty strong family history for sudden death. So he presented to a community hospital ER complaining of a 3-day history of shortness of breath, fatigue, and pre-syncope. And this was the EKG. So as you could see, a wide complex tachycardia, and there was that notion of fascicular VT, but this is really too wide to be fascicular, but it was monomorphic the entire time. So in that community hospital, his troponins initially were negative. He had a blood pressure. He was started on amiodarone IV. He got 2 cardioversions. He got a trial of esmolol, but he arrested with a downtime of less than 1 minute. He was intubated, started on pressors, and transferred to Toronto General Hospital, which is the main ECMO center in the Greater Toronto area in Ontario. So this is his echo on arrival. So as you can see, a severely reduced EF called 5% with severe RV dysfunction. There's some annular motion, but otherwise the FAC was in the severe range. So on arrival, he was on epi, norepi, and phenyl. His lactates were rising. He was oliguric, requiring renal replacement therapy. He was in shock liver, and he had persistent and refractory VT despite therapy, which was started. He was deeply sedated at that point. So he was in organ failure, but as you know, it's not all over, or else I wouldn't be here to talk about this case. So at this moment, there was a few questions as to which support would suit our patient best. So these are the options that we all face when we see these patients. So it was thought that IABP would not provide enough support, obviously. It was also thought that VAD would probably not be the best considering his RV failure at this moment and the potential for recovery or not. And we're pretty strong on ECMO center, and we don't do tandem heart, so we decided to go straight to ECMO. So we use VA ECMO in this patient with refractory ventricular tachycardia as a bridge really to maybe he was going to recover. He was a young guy. Did not seem like myocarditis, but there may be a chance for recovery if we address the arrhythmia. For potential heart transplantation, if things don't get better, because he is young with no red flags, at least on our assessment, or potential durable mechanical circulatory support as a bridge to candidacy or a bridge to transplantation. So ultimately, VA ECMO served as a bridge to decision. So on day 2, first day at our center, he was cannulated. So it was a peripheral VA ECMO cannulation with a 25 French drainage cannula placed in the left femoral vein, a 17 French return cannula in the right common femoral artery. We put 6 French cannulas for distal perfusion in the femoral artery as well. And his initial settings were, he was able to get a flow of 4.5 liters per minute. We always put our FiO2s initial at 100 with a sweep of 3. And at that time, he was having a pulse pressure of 10-15 millimeters of mercury. So we felt that there was some aortic valve opening and some decompression of the left ventricle. However, over the next 24 hours, despite amiodarone and lidocaine IV, deep sedation, multiple failed attempts to wean epinephrine, he had a pulse pressure that dropped less than 10, and we even tried to aggressively diurese him, and at this moment, we weren't getting anywhere. And although his EKG showed some breakthrough, for the vast part, he was still in this monomorphic ventricular tachycardia. And this is his echo on peripheral VA. So as you can see, a dilated left ventricle. The EF is not any better, the RV either. And when we looked at the diameter, as you could see, is dilated, and there was the clip is not long enough, but there was really intermittent aortic valve opening. So then I think this was like the most important discussion that was had. It was a really multidisciplinary discussion and what we decided to do is to, first of all, let's unload the LV, and the go-to method at our center is atrial septostomy and direct LA vent. We then decided to go for VT mapping. It was actually funny because the EPs called us like, we can't find you. Where are you guys? Like, where's the ICU? So it was nice to have them part of our discussion. VT mapping and an ablation attempt. And at the same time have some of the interventional cardiologists go in to not only unload the ventricle, do a myocardial biopsy just to rule out any myocardial inflammatory process, and also perform a coronary angiogram just to tick off all the boxes. So he went for his procedure. The VT mapping identified an epicardial focus. However, there was a complication of an RV puncture, went straight to the OR, and these are the images we have. So not only did they repair the RV perforation, but they were able to use the epicardial mapping in order to address, and the EPs actually went in the room with their mapping and ablated the focus. And he continued improving, no VT. He actually did not have a single PVC thereafter. And just because I'm short on time, he was eventually decannulated. We bring them down to 1 liter. We don't turn it off at 0. Went home to rehab. And this is the last echo I found just before coming here. So 40% on medical therapy, not even for VAD right now. So maybe one day, but right now he's doing better. So this is a bridge in Montreal. There's no bridges in Toronto. I'm from Montreal, so it serves as a bridge to decision in this patient, and it should be used in our algorithm for VT that I'm sure you'll hear about. And that's about it. I also, just if you could keep this slide on, I'm part of the Canadian Cardiovascular Critical Care Society, and we started doing, like, I really don't get paid for this, so this is not a conflict, but we started doing these virtual journal clubs that have been attended by a few people in the States and Canada. So if you could follow the Can Care Society on Twitter, we're actually discussing the meta-analysis that was presented in the past on with the first author and Dr. Patrick Lawler from TGH, who train in the States, so you're more than welcome to log in for free. It'd be nice to have everyone's input because the same questions always arise.
Thank you.
Thank you.
Great. Now, what did the biopsy show? There was a question from there.
It showed kind of, the non-specific stuff that the pathologists always say, but really it was not in keeping with definitely not giant cell and definitely not like inflammatory myocarditis. But we had that feeling because the troponins on arrival were negative. So we think he probably was going into VT for a while, wasn't complaining much, and then kind of went into a vicious cycle of ongoing VT and cardiogenic
But this was
shock.
not some channelopathy, because if I read it right, there were two
Yeah, so
family members
he's
died
in the
sudden
process
cardiac
of
death
getting
also.
genetically screened. His son is 1 year old, also getting screened. It's not long QT, it's not Brugada. I reviewed the notes from the clinic before coming, and it's probably something, but it's still not diagnosed.
Well, there's an EP question coming. Go for it.
A question for the panel and for the speaker. So obviously this is a situation that at our center we see not too uncommonly, but different etiologies. And the question always arises, which, a pleasant but interesting debate between the heart failure and the electrophysiologist, the team, is what comes first, the heart failure or the VT? And is unloading the ventricle going to be the answer to solving the VT storm, or is it going to be ablation as the answer for VT storm? So, and then as a segue to our upcoming talks, I think I'd like to ask the panel and any experts who have any thoughts on this issue.
I would take that, because that's the clinical setting. If the patients had a primary arrhythmia and then went into heart failure, that is the arrhythmia causing it. But like Dr. Fraser used to say, the most powerful antiarrhythmic is unloading the ventricle. If the arrhythmia started after the ventricle started failing big time, not this case where he had a CMR with a EF of 53% just 2 weeks earlier, and now he's having a malignant VT, 2 years earlier, having malignant VT. Having said that, between the two extremes where the clear cut, there are gray areas where you don't know which came first, chicken or the egg, and that I think as you treat and you get more experience, you'll find out.
And in this particular case, I think a good surrogate for LA pressure over time to suggest, or in this case, not heart failure, is his LA volumes, and RA volumes they didn't seem enlarged. And so I think the dysrhythmia with his clinical history suggests that the rhythm disturbance is the primary culprit.
Exactly.
But I thought the LVIDD was 6.1.
No,
or
but that
something.
was when he was on peripheral VA
Yeah.
ECMO.
No, his LV remodeled, but his left atrium, right?
Yeah,
If he
no,
were-
it wasn't so. But we actually felt it was kind of like a subacute process that just acutely decompensated over the past few days.
But I'm sure the EP guys will mention your EKG was very clear, at least as clear as it can be, that the focus was epicardial.
The comment that I was going to make was that instead of inadvertently accessing the pericardium as they did with the RV, it would have been better to upfront access the epicardium.
Yeah, it
and
looked like an
just
epicardial VT.
to map both the epicardium and endocardium. It's a high likelihood that this was epicardial to begin with.